Test. This is our weekly presentation. So what is pulmonary function test? It is a group of non-invasive tests that measures how the lungs are working. We usually assess lung volume, capacity, rates of flow, and gas exchange. It is a primary tool which is used by surgeons and pulmonologists to determine if a patient is a good candidate for lung resection or surgery and how much lung can be safely removed. Pulmonary function test normally with the spirometry, where we see FPC, FEV1, FEV1 by FPC. We can also see the lung volumes and ventilation. For that, we use body plethysmograph or nitrogen washout or helium dilation test. Or we can also use diffusion lung capacity test, uh, diffusion lung of carbon monoxide, and we also can use cardiopulmonary exercise test. Today we will be mainly focusing on the spirometry, which is usually readily available in our hospital. What is spirometry? Its literal meaning is measuring of the breath. Here we measure the amount or volume and the speed or the flow of the inhale and exhale here. So this is a typical presentation of a setup of spirometry. Here there is a spirometry machine. There is our patient who blows the mouthpiece, and then we also use a nose clip uh, so that the air doesn't go off from the nose, and the recordings are seen as a in the graph as you have seen there. Before knowing about the spirometry, we should know about the lung volume and the capacities. As you can see in the picture, the middle, the oscillations like waves are of the tidal volume. Tidal volume are the normal volume of air, that is, we inspire and expire in the normal breathing. But even above it, there is a inspirator reserve volume. That means the volume that can be used if we use excessive effort. So the above the tidal volume, if how much the lung can expand and how much the lung air the lung can accumulate is known as inspirator reserve volume. Likewise, there is expirator reserve volume.
Can you show the pointer in the center?
Yes, sir. So this is the expirator reserve volume. Here, in normal respiration, this is the tidal volume. And now if we apply more effort, then it will be the expirator reserve volume. Then there is a residual volume. This is also important because this helps to keep the lungs patent, and this can be measured by our spirometry, because during inhalation and exhalation of air, this is not in the circulation. And there are also capacities like inspiratory capacities. Inspiratory capacity is the tidal volume and the inspiratory volume. Combined, we get the inspiratory capacity. Then there is the vital capacity. As you know, vital means it's important, means it's vital for our body. So this consists of all the oxygenation that take place, like inspiratory volume, tidal volume, and expiratory volume. Then at last there is total lung capacity. This is the vital capacity and the residual volume that we usually are not using. Total is called total lung capacity. So when should we send a patient for spirometry? It is used by pulmonologists for the evaluation of respiratory diseases like screening. We also use it for pre-operative evaluation to test the lung function. And after the treatment, if how is the patient doing, how is the treatment going on, its effects, if we can follow up also by spirometry. So when not to send spirometry? You should not send a patient for spirometry if there is hemoptysis, if there is pneumothorax because it increases the pneumo. If there is Last bulla, there is risk of rupture. Or if there is recent history of myocardial infarction, pulmonary embolism, cataract, or CNS surgery within 4 weeks. And also, we should not do spirometry if the patient is in active pulmonary infection or pulmonary tuberculosis because there is chance of spreading to other people also. So pre-test instruction. What should you instruct a person or a patient before before asking them to come for the spirometry? We should tell the regular medication. These are regular medication used by the patients, like short-acting beta agonist, salbutamol. It has to be written for 6 hours. Long-acting beta agonists, like formoterol, should be stopped for 24 hours. Short-acting muscarinic antagonists, uh, like ipratropium, should be written for 12 hours, and tiotropium should be written for 36 hours. We should we should also ask the patient that they should not smoke or use vape or shisha, and or even heavy work before 1 hour of the test. This patient should not use any intoxications like alcohol for 8 hours, and patient should use comfortable clothes like restrictive clothes should be avoided. So how is the procedure done? The patient is asked should inhale fully, and then only he has to exhale, because we have to uh, uh, measure the vital capacity. Vital capacity means after the total inhalation or total forceful inspiration, then only vital capacity can be measured. So this will be forceful, continuous, and at least 6 seconds. We have to ask the patient to forceful exhale in the machine. We should also know that if most vital capacity FEV1 between the two breaths should not be more than 0.15 liter, and FIVC and FVC, the difference between them should be less than 100 ml. If it is not so, we have to repeat the test again. Normally, at least 3 breaths are taken, and the highest values of each test are taken as our uh, um, report. So, spirometry, we are usually looking for the coughs and the graphs. There are two types of uh, coughs and graphs. One is a classical spirogram, where we see volume with time, and another is a volume curve, flow volume curve, where we see flow, that is volume per time against volume. So I see here. So these are the two types of graphs. This is a classic spirogram. You can see here the patient expiring, and the volume, we are measuring the volume of exhale here, and it is against the time. So it is the volume time curve. And below there is a flow volume curve. Flow means how much the patient has expired in liter and in unit time. And so another is flow, and there is also volume. In the horizontal line there is a volume. In the vertical there is a flow. This is above one is expiration, and below one is the expiration. Yes, inspiration, above is the expiration. So this is a normal volume time graph. The above, yes, this is the normal one. The above you can see the patient is expiring, and is exhaling the air, and in 1 second, this is the time 1 second. How much he has expired in 1 second? It is called the FE1. It usually should be more than 70%. Okay. Then, if a patient is suffering from obstructive disease, means he is not expiring, is not able to expire as much due to obstruction. So the first FEBR will be less. In 1 second, you can see previously it was above, now it's very less. In the restrictive diseases, usually the vital capacity will be the change. So this is a normal. As you can see, if FEBR should be normally 75 to 85%, and if it is not, we can say it's the obstructive disease. So these are some diseases where depicted by the flow volume loop. So in the black color, we can see the normal flow volume loop. The patient expiring, then the slowly decreases, then their expiration again starts. If there is obstructive lung disease, if the FEV1, the flow doesn't reaches up to the top, then it makes a concavity and reaches less uh, by volume. Normally, volume is usually reduced in obstructive. In restrictive, normally you feel that the volume will be decreased. And there is also fixed area of upper airway obstruction. We will also see. So by this is a typical presentation. Here we are seeing what is the pattern of FEV1 by FVC. FEV1 means forced expiratory volume, and FVC is the capacity it has. So if there is obstruction in the airway, it is normal that there will be less FEV1. So FEV1 FVC will decrease. In restricted patient, the patient will not be able to, like in the interstitial lung disease, the lung capacity alveoli will not expand. So FEV1 may be normal, but the forced vital capacity will be decreased. So this is the other pathophysiology of the disease. FEV1 will be decreased in the respective obstructive cases. So with the cough, we can also see the severity of the diseases of the obstructive disease. Like you can, as the cough goes down, there will be the severity will be increased. So we can, if you see the cough, we can also detect less, the concavity will be greater, and the vital capacity will also not be reached. So this is all the same. Here we are depicting the restrictive pattern. As you see in the restrictive pattern, the forced vital capacity will not be reached because the lung will not be expanding. Same here. So another thing we can see in the spirometry is the obstruction or types of obstruction. There can be three types of obstruction. One obstruction is fixed obstruction, as you can see here. Another are variable obstruction. Variable obstruction can be intrathoracic or extrathoracic. Let's see of the fixed obstruction. In the fixed obstruction, the flow will be obstructed in both, same amount of the obstruction will be present in the inspiration and expiration. So you can see the cough here. But if there is interthoracic obstruction, like in an interthoracic tracheal mask, what will be there? During the inspiration, as you can see above, as the lung expand, the trachea will also simultaneously expand. So inspiration, there will be any effect. But during expiration, the obstruction will be, because as the lung contracts, trachea also contracts, and there will be, the obstruction will be seen. Now we see of the extrathoracic obstruction, like vocal cord palsy or something like that. Yeah, and the pattern is like different. Like during the inspiration, due to the negative pressure created, it will cause a contraction of the pathway. But in expiration, it won't be affected, and the volume curve will be normal. So this is the same. Mhm. There is also, we can also see the reversibility criteria. So is and the obstructive airway is how severe it is. Like for the checking the reversibility, we usually give salbutamol 200 to 400 mcg and see the repeat the spirometry. If there is improvement in the FEV1 or FEVC by greater than 12% or greater than 200 ml, we see that it's a reversible. And usually in asthma it's reversible. Like in children, it's the same. We don't uh, take volume, we just take the 12% as the criteria. As you can see, for adults, FEV and FVC is less than 0.70, obstructive, and it's in the asthma. So these are some of the patterns. It's the same we have studied before. Like in obstructive cases, we have to look out for the peak expiratory flow rate and the concavity. Peak expiratory flow rate will decrease and concavity will be present. In restrictive pattern, we have to see the vital capacity. Has the vital capacity reached or not? If the vital capacity is less than 2 liter, then we have to see it's a restrictive vital disease. Like, this is the fixed obstruction kind of case, and as I've seen, there will be extrathoracic and interthoracic. So these are some of the graphs, like asthma, emphysema, restrictive diseases, interthoracic, extrathoracic, and fixed obstruction. Unacceptable pattern. When should we say the report will be unacceptable? Like if the patient coughs in the start of the uh, spirometry if he's not applying good effort. Um, Normally these are two. But if there is a cough at the end of the expiration, then we have to take it as an acceptable pattern that we use here. You can see the graph here. This is the FEV1. Yep. Yes. So normally how we mm, say how we detect how we analyze the report. We usually use the FEV1 by FBC ratio. If it is less than 70%, we know it's obstructive. Then we see about the FBC. If the FBC is normal, it is obstructive airway only, and it's mild or more obstructive, but there is no restrictive component. As I already said, the restrictive component will always be having FBC, but if normal, there is no restrictive component. But if FBC reduce, then you usually have the restrictive component. Or if the obstruction is very severe obstruction also, FBC will be reduced. So let's say if FBC is normal or greater than 70%, then we see FEV1 by FBC ratio. Then we FBC. If FBC is normal, the patient is normal. But if FBC reduced, then we have to suggest that these are restricted lung diseases. So what the spirometry can't measure? Spirometry can't measure residual volume, residual volume, and also it can also measure total lung capacity and uh, FRC. So for this we have to use DLCO or plethysmograph. Thank you.
Thank you, Dr. Solan. So, के कमेन्ट्सहरू छ केही तपाईँले केही यसमा एड गर्नुहुन्छ Dr. Reju? So, what's your interpretation? How often do you, Dr. Jadhav? This is a pulmonologist, and critical care fellow from CLC. What's your opinion? What do you think that in our routine practice, how often would you recommend this spirometry as a general test in your clinic? In every basis, so do you interpret it and what kind of information do you have? What kind of people and what kind of patient do come to your office? Restrictive pattern or obstructive pattern generally? If you see 100 patients, how many of them have the obstructive, restrictive, or the mixed pattern? So in case of in our pulmonary OPD, obstructive pattern is common, and in per day we do up to 5 to 6 spirometry per day. Among them, 4 to 5 is obstructive cause, and only few of them are in restrictive, such as in case of ILD, digital lung disease, and most of the cases are of obstructive cause, such as bronchial asthma and COPD cases. So, few things that I would like to add on, Dr. Salman. First, you put the picture of the spirometry. It's a quite older version of the picture, but when it was in the 90s, perhaps. Those kind of spirometries are possibly not available. They're the very tiny ones, not so bulky. They're too bulky, the older versions. So those kind of things are not available right now. A very small device is a portable device you can use in the clinic or PD also. Okay, this first thing. Second, you did not mention was the spirometry done properly or not? We need to calibrate the spirometer, and we have to. You mentioned just briefly that whether this spirometer is erroneous or it was done properly, because the interpretation will be different. If the patient has not performed well, and you can take the measurements given by the report, developed by the report itself, then that will lead to your diagnosis mistakenly. First is the diagnostic test, it is the physiological test, right? You cannot make a diagnosis on the basis of spirometry. You can just study the physiology of the patient, right? So how good or what is the physiological phenomenon in the body? So can you say something, highlight something regarding what are the calibration tests or maneuvers, or what do you think? What should be seen whether the patient has correctly performed the test or not? One thing you mentioned, can you say something? Yeah, yeah. मेरो क्वेसन बुझ्यो नि the spirometry was done we don't know whether यो good quality छ कि नि quality assessment के spirometry was done जसरी हाम्रो ल्याब टेस्ट गर्छौँ बायोकेमिकल्स रुटिनली उनीहरूले क्यालिब्रेसन गर्छ इन द मर्निङ it is recommended that spirometry should be done calibrated every day in the morning before you start the procedure. So first thing you mentioned कि 3 tests have to be done. पहिला त आफै भनेको छ 3 breaths means 3 tests. So whenever the report comes, you have to repeat the same thing 3 times for the patient. One. Second, you mentioned the difference between the 3 tests. FEV1 by LBC ratio should not be more than 115. 150. Again, if it comes more than 150, it means there is something wrong. Patient was not taught properly, or nose was not clamped, something missing, or the lips were not closed, sealed properly, leak भइरहेछ भने एरर दिन्छ रिपोर्टिङमा त्यो चाहिँ हामीले जान्न जरुरी हुन्छ सेकेन्ड थिङ यो हो थर्ड यु लुक एट द कर्भ तपाईँले कर्भ देखाउँदाखेरि यस्तै पुरै थियो भोल्युम कर्भ यदि कति जिगज्याग आइरहेछ एउटा पिक्चरमा देखाएको थियो इट मिन्स पेसेन्ट हेज कफ्ड इन बिट्विन interrupted in between that test was not properly done and as a good spirometer तपाईँको पिक्चर यदि has done 6 minutes 6 seconds सम्म उसले गरेको छ भने this is a good quality of test यदि somebody does for just only फु गर्यो भने सेकेन्डमा गरिदियो this you cannot report it properly either एकदमै massive severe obstruction मा छ वा चाहिँ the test was not properly त्यही भएर you have हाम्रो चाहिँ assumption के हुन्छ at least breathe out, exhale 6 seconds so that you can obtain a good quality of curve. So that was one thing that I wanted to highlight. Second thing, you mentioned everywhere. I would like to request Dr. Rezu. That was the guideline that is suggested in 2005. European Respiratory Society, sir, or American Thoracic Society, British Thoracic, generally 3 societies are there who published the guidelines regarding all this stuff. So whatever you said was the European Respiratory Society 2005 fifth version 2005. So that is no more implemented. So उनीहरूले अहिलेको guideline which was published 2021 or American Society guidelines says कि तपाईँको FEV1 more than 70% is normal, right? Or FEV1 ratio of FBC more than 70% is normal, right? But they say that it should not be done. Your recommendation is not, right? So the now scoring is the Z score. त्यही भएर हाम्रो इन्टरप्रिटेसनमा जेड स्कोर नै आउँछ जेड स्कोर जसरी हामी यो बेल प्याटर्नको कर्भ जुन लिन्छौँ नि सो त्यही द लोवर लिमिट अफ द नर्मल यसरी बेलको पिक्चर भयो भने यतातिरको कर्भ जुन चाहिँ एरर भन्छ नि 5% एरर दिस साइड or दिस साइड सो लोवर लिमिट विल बी टु द लेफ्ट साइड जेरो बिचमा हुन्छ भनेर कर्भ डायग्राम गर्ने हो भने okay this is the curve that we obtain, right? So this is the zero. This is the negative point minus. This is the positive point. So this 5% at which have my score. So that should be the 5%. So that corresponds to the given. So 1.65. You minus 0, 1.65 with the plus 0, right? So they said if anything is lies above minus 1.65 going towards the positivity, that is supposed to be normal. If something exists beyond plus 1.65, it means not even beyond 1, even beyond plus 4, then this is he has got possibly some of the high lung total lung capacity. Maybe different. You cannot interpret it by that spirometer because it is just simply the physiological test. You cannot measure it as you said total lung capacity or residual flow. There are you have to study further by some other means. Only minus 1.65 is the cutoff. If something is less than minus 1.65, then use the Z score. It is called the Z score. So if it is less than minus 1.65, then you suspect the patient has got the obstruction, right? There was severity पनि छ minus 1.65 देखि minus 2 सम्म छ भने mild भन्छ minus 2 देखि minus 4 सम्म छ भने moderate भन्छ even minus 4 भन्दा झन् कम छ भने that is the severe. So severity gold criteria of the COPD, right? Gold criteria, they have mentioned the same thing. Therefore, if somebody asks you, don't mention the ratio 70%. Now it's not being any more utilized in the clinical practice. Therefore, Z score हामीले भन्न जरुरी छ, ठीक छ? Second point मैले त्यो भन्न खोजेँ. Third say you have not mentioned anything regarding the reversibility. Quite often she said the patient comes with the bronchial asthma, and these tests have to be done pre-bronchodilator, without bronchodilator, without beta agonist, and with the beta agonist. That's why you said that at least 6 hours for the short acting and maybe 24 hours for the long acting. And the beta agonists have to be avoided, abandoned. They were pure tests are there before bronchodilator and after use the bronchodilator. You have to use. You mentioned in one of the slides the reversibility criteria, whether it is reversible or not. Reversible means before bronchodilator, let's suppose the patient has got the obstruction. Now, after use of the bronchodilator, if it is increases more than 12%, right? It's Isn't that in the opposition use 10%. 10%. So if it increases more than 10% before 200 ml बंद हो गया तो ऐसा sorry so more than 10%, then it is supposed to be a reversible case and you diagnose the bronchial asthma rather than the COPD. COPD में reversible हुँदैन भनेपछि you diagnose the bronchial asthma. This thing is included in the spirometry test, right? So you and whatever the pictures we have said that are very good. Definitely we cannot measure the total lung capacity. We cannot measure the residual volume. So these things cannot be measured, but at least physiological testing have to be measured. र मैले चाहेको के भने वेयर सर्जन्स यसको इम्प्लिमेन्टेसन तपाईँ कसरी गर्ने हो त? It's not our job, big job to diagnose the restrictive pattern, obstructive pattern, COPD or asthma. Those patients will go to her. So our practice when we are taking the patient for the surgery, if you are not prepared next time, prepare it. How will you calculate on the basis of the spirometry? The patient is having a normal risk, moderate risk, or high risk for the surgery. Just only on the basis of spirometry, because in our institution, as of now, we do not have the DLCO. We do not have the plethysmography. So all those tests cannot be done in our institution. What we can do is simply the spirometer and the exercise pulmonary testing. CPET हामी CMC पठाउन सक्छौँ वा सम्ले 6 minute walk test गर्न सक्छौँ shuttle test 6 minute shuttle test गरेर stair climbing गर्न सक्छौँ. That is equivalent to the CPET हैन. त्यही भएर त्यो हामी something हामी गर्न सक्छौँ, but अरू लङ भोल्युमहरू हामी निकाल्न सक्दैनौँ. ठिक छ, त्यो चाहिँ पनि हामीले जान्नु जरुरी छ. अर्को भेरी महत्त्वपूर्ण तिमीले कर्भ त देखायो, हाउ वुड यु इन्टरप्रिट इट? जस्तो कि तिमीले यो कर्भ देखायो, एकदमै जेन्युन कुरो हो कि हामीले थ्योरिटिकली भन्नु जस्तो कि तिमीले कर्भ देखायो यसरी आएको छैन, यसरी गइरहेको छ. So in a normal, you said this is the normal curve. यदि कसैको कर्भ starts like this, यो मानौ 1 second भयो, 2 second भयो, 3 second भयो, 4, 5, 6, etc. अब कुनै बिरामीको यसरी गएको छ, यो 1 भयो, 2 भयो, 3. What you would diagnose this as? के हो? Obstruction छ, right? Obstructive pattern भने why? किनभने यसको जनरल नर्मल आफै भने कि 1 सेकेन्डमा यो चाहिँ राइज गर्छ about 70% जति they will FE1 will reach to FE1 will approximate 70% of the FRC. उसको जुन फङ्सनल vital capacity force vital FBC छ उसको 70% will be approximately the FEV1. FEV1 त्यो पहिलाको गाइडलाइनमा त्यही त भन्थ्यो 70%. So this 70% will be of the force vital capacity. If somebody doesn't get 70%, the next curve was like this. Obviously, this is not 70%. And 70 थियो, 80 थियो, etc. So this was too low. Therefore, हामीले obstruction भने एक. Obstruction को एउटा second के छ भने अर्को स्लाइडमा तिमीले भन्न त भन्यो तर के बुझ्यो थाहा छैन. You said besides FEV1, you mentioned that there are the role of FEV2 भनिहाल्छ त्यहाँबाट. FEV3 तिमी आफ्नै स्लाइडमा आइरहेछ भने that in the 1 second only. Look at the 2 second, 3 seconds. So what they say at the end of the 2 seconds, generally 80-85% of the FBC will be achieved. At the end of the 3 seconds, maybe 95% will be done. There will be the plateau thereafter. Thereafter, कुनै पनि यो कर्भको चेन्ज आउँदैन. यो नर्मल कर्भ. बट यदि COPD पेसेन्टलाई गरौँ भने हामीले नर्मल पर्सनले 7 मिनट 8 सेकेन्ड 7 सेकेन्ड 8 सेकेन्डसम्म ब्लो आउट गर्न सक्छ भने COPD को गर्यो भने उसले गरे गर्छ क्या. उसको यो कर्भ चाहिँ प्लाटो रिच गर्न टाइम लाग्छ. But they will consider maybe 10 seconds, 11 seconds. That will also हामीले एक मानेमा के बुझ्छ भने the patient has got the obstructive pattern. बुझेको सेकेन्ड अर्को जुन भलुमको कर्भ देखाएको छ त्यो अवसर यो हाम्रो जजमेन्ट हामी सर्जन धेरै कुरो जान्न पर्दैन जस्ट भिजुअली इन्टरप्रिटेड गर्दा कस्तो देखिन्छ जान्न जरुरी छ सेकेन्ड चाहिँ हामीले कति देखेको छ भने यो कर्भ देखाएर यो भलुम दिस द एक्सपिरेसन दिस इज द इन्सपिरेसन ठिक छ होइन एउटा भलुम त उसले एचिभ त गर्छ नि यदि कुनैको हाम्रो लागि बढी मल्टिपल लङ क्यान्सरको पेसेन्टहरू जेनरली आउँछ सब्सट्रक्टिभ प्याटर्न हाम्रो कहिले कम हुन्छ COPD and they generally near posture. Smoking causes the COPD, and also the lung cancer. They are mostly associated with this obstructive pattern mandate syndrome. यदि यस्तो कारण भएर कसैको यस्तो आइरहेछ भने think it is the obstruction. यो पनि हामीले जान्न जरुरी छ हैन अरु केही कमेन्ट छ तपाईले के एड गर्नुहुन्छ कि अरु चीज के हाम्रो सर्जिकल इम्पोर्टेन्सको लागि अरु के तपाईलाई के लाग्छ अरु के एड गर्नुपर्ने छ
यो एक्सपेक्टेडमा जस्तै FEV1 पिक पुग्यो त्यस पछाडि फर्स्ट 70% त फर्स्ट सेकेन्डमा जति एक्सपायर गर्यो त्यति देखिने भयो त्यस पछाडि त्यो कर्भ चाहिँ कसरी आउँछ त्यस पछाडि जस्तै यङ पेसेन्टहरूमा चाहिँ स्मल एरिया अब्स्ट्रक्सनहरू जुन हुन सक्छ त्यसमा चाहिँ
राइट भन्नु भन्नु
स्मल एयरवे फर्स्ट सुरुको फर्स्ट
25%
एयर भयो त्यस पछाडिको जुन त्यो पछि यो जुन त्यो हाम्रो कन्केभ आउन थाल्छ कन्केभ आउन थालेको पार्टबाट पनि माथिको फर्स्ट FEV1 नर्मलै भए पनि कन्केभिटी पनि हेरेर पनि त्यसमा एयरवे डिजिज छ भनेर
Exactly. So they measure 25%, 50%, 75%, right? Of the peak expiratory flow. त्यो पनि त्यो हाम्रो PFT को उसमा चाहिँ देखिन्छ दे आर द माइनर डिटेल्स ठिकै हो त्यो तिमीलाई केही क्वेसन छ भन तिमीले बुझेन होला यी चिजहरू बट वाट एभर जान्न जरुरी छ एक्जाममा समटाइम्स
हजुर एज अ थोरासिक सर्जन एक्सपिरियन्स हुन्छ अब कुनै त्यस्तो प्यारामिटर छ सर तपाईँले चाहिँ प्रेडिक्ट गर्न सक्ने पोस्ट अपरेटिभ कम्प्लिकेसन जस्तै FEV1 TLCO हेरेर कुनै त्यस्तो प्यारामिटर
गाइडलाइन नै छ गाइडलाइन नै छ प्रेडिक्टिभ पोस्ट अपरेटिभ FEV1 कति हुन्छ predictive post of DLCO कति हुन्छ the guideline नै establish गरे if somebody has got less than 20% predictive post operative no surgery 20% देखि 40% छ भने again you should be very cautious your mortality rate very high but you can do the CPET and determine generally rule of thumb के छ भने if both predicted post operative मतलब सर्जरी गरिसकेपछि उसको प्रेडिक्सन हामी पहिल्यै डिटरमाइन गर्छ उसको FEV1 कति हुनेछ DLCO कति हुनेछ दुईटै यदि not or दुईटै both are more than 40% then you can carry out any sort of surgery general rule of thumb त्यो तर हामीसँग DLCO छैन त्यही हामी के गर्छौं भने बिरामी दुई तल्ला चढाएर यदि somebody can climb the stair त्यो पनि स्टेयर सानो सानो उसको हाइटहरु युरोपियन स्टाइलको सानो मसिनो स्टेप्स हैन यो ल्याडर दुई तल्ला चढ्न सक्छ मोर देन विदाउट डिस्याचुरेसन अफ मोर देन 4% छ भने दे क्यान टोलरेट न्युमोनेक्टोमी एउटा कुरो चाहिँ जेनरल रुल अफ थम्ब चाहिँ यसरी हो चढाएर हामी पनि सोध्छ तिमी जोड्न सक्छौ छैन हिँड्न सक्छौ कि सक्दैनौ 6 मिनट वाक त्यस्तो त्यसमा तपाईँ आफू बस्नुपर्छ कोहीजना बस्नु पनि फलोअप गर्नु पर्यो हैन त्यही भएर हामीले रुटिनली आफ्नो क्लिनिकमा प्र्याक्टिस गर्ने चढ्ने अब त्यो पनि कसले हेर्न जान्छ हामी त राउन्ड लिँदै बिरामीले उठ्छ 25 चोटि 30 चोटि गर त्यसपछि उसको हार्ट रेट हेर्छौ स्याचुरेसन हेर्छौ र आफ्टर रिग्रेस एक्सरसाइज लाइक 70 इयर्सको मान्छेले 20-25 चोटि उठबस गरे डिस्याचुरेसन लेस देन 4% बनाएको छ भने वी सस्पेक्ट कि हो हामीले एच्युम गर्छौँ क्यान्टोरेटल सर्जरी हैन जनरल FEV1 अफ कोर्स यदि कसैको चाहिँ जनरल रुल के भन्छ न्युमोनेक्टोमीको लागि 2 लिटर हो लोबेक्टोमीको लागि 10 लिटर हो अनि वेज रिसेक्सन सब लोबर रिसेक्सनको लागि 800 ml हो यो रफ आइडिया हो यो पुरा र पुरा बट नोबडी फलो